Thank you for joining this session on lithotripsy. And I think we are all aware that things have changed in this area in recent times. First of all, at the beginning of 2019, in the pre-COVID era, we had the NICE guidelines. And then we've also had GIRF guidelines talking about centralization and changes with lithotripsy services. And then all of this has been turned on its head in the COVID era. And we've tried to change how we manage patients acutely with stones to minimize their time in theatre, and maybe to change the way we manage stones to optimize their outpatient management. And so this session really brings together various talks around how to set up a service and optimize a service, particularly in the light of these guidelines and also in the current clinical climate. So just to remind you, back at the beginning of 2019, which now feels like a very, very long time ago, the NICE guidelines were published on the management of renal and ureteric stones. And these guidelines were perhaps slightly surprising in that lithotripsy became very prominent in the guidelines compared to other international guidelines. And these two tables really summarize the role of lithotripsy. On the left, you can see how NICE recommends we manage kidney stones, and on the right, ureteric stones. And as you can see here, for stones less than 10 millimeters, lithotripsy is recommended as first-line treatment for adults. And even for stones that are between 10 and 20 millimeters, lithotripsy is given sort of equal footing with ureteroscopy. And when it comes to ureteric stones, again, lithotripsy is first-line treatment for smaller stones less than 10 millimeters. And even the big ones in the ureter, it says lithotripsy should be considered if local facilities allow for rapid clearance within 4 weeks. So potentially all stones in the upper urinary tract less than 20 millimeters could or should, according to these guidelines, have shockwave lithotripsy as a first-line option. Why was lithotripsy given such prominent focus in these guidelines? This graph is from HES data, and it shows over the last 15 years, from the beginning of the century to 2015, the changes in procedures, common procedures in urology. And like many countries around the world, over the latter half of this period, you can see a very sharp rise in the numbers of ureteroscopies. And unlike other countries, lithotripsy in the UK has maintained a reasonable level, whereas in many other countries around the world, this has fallen dramatically. Why have the NICE guidelines focused on this? Well, this paper from the end of 2019 looked at the cost effectiveness of shockwave lithotripsy. And for a stone episode, a ureteric stone episode, lithotripsy was far, far cheaper than ureteroscopy, over £2,000 cheaper. And even when you reduce the effectiveness of lithotripsy, maybe down to 40%, it still seemed cost effective to try lithotripsy first. So the question was, after the NICE guidelines were published, will we need more lithotripsy service? Yes, almost certainly, if they're going to be followed. We need a clear understanding of how it works, and we need to know how to get the best out of our machines to give the best results for patients. COVID obviously has turned everything upside down, but actually it may also push us more towards shockwave lithotripsy. It avoids a general anesthetic. We now have a period where waiting lists are growing for benign conditions due to pressures on services, and lithotripsy offers an outpatient option that potentially can continue throughout. And many shockwave lithotripsy services have really offered a crucial support during this period for patients with ureteric stones in acute pain. So will all of this herald a new enthusiasm for shockwave lithotripsy? There's lots of things pushing in this direction, but will it translate into reality? So today we have these talks from experts around the world. The first talk will be around how to set up a stone service from Finch. And then we're joined by Will Roberts, from the University of Michigan. He's going to talk about analgesia and the coupling and physics around shockwave lithotripsy. And then Hanna, who's a recognized lithotripsy expert in London, will give us some top tips about how to get the best out of a lithotripsy machine. And then Steve Gordon will conclude this session talking about his experience with shockwave lithotripsy in the COVID era. I hope you enjoy the talks. Thank you.
So good evening, everybody. My name is Will Finch, and I'm a consultant urologist up in Norwich, and I've been asked as part of this lithotripsy session to talk briefly about setting up a lithotripsy service and within a network. So the background to our ureteric lithotripsy service is off the back of the GIRFT reports, which showed a significant variation in the management of colic across the country, with many people being stented potentially unnecessarily. The NICE guidance from 2019 suggested that we should be offering surgical options and lithotripsy options acutely to people with ongoing pain or stones that were unlikely to pass. And so on the back of this, in October 2018, we introduced and started an acute lithotripsy service at the Norfolk and Norwich. And then in April this year, we became one of the first STPs in the country. And that was the integration and amalgamation of 3 urology departments across 3 acute trusts in Norfolk. So we're now a department delivering urology to 1.1 million people geographically spread across Norfolk up in the east of England. And we also take tertiary referrals from neighbouring trusts in Suffolk and Cambridgeshire. So that's the background to it. And when setting up any service, what have I learned? Well, the most important thing is understanding what your service is before you start. And so we spent a lot of time with our operational team, process mapping our current stone pathways, and for 6 months did an audit to understand what the management of our emergency stone workload really was. And as part of that audit, the key question was, if we had acute lithotripsy or hot lithotripsy, what proportion of people would we treat differently? So within that audit, we identified very quickly, before we'd even started, what the need for lithotripsy was acutely. We then had a look at the actual machines themselves, and it's important to understand what machine you're going to use. Is it a fixed site machine that you have already or need to update, or you're looking to capital purchase a new machine? As part of any fixed site machine, staffing is really important because it can't run without that, and it's important to factor that in. We work with a mobile lithotripsy provider, and it was important to understand the ability for them to expand their service and their availability for that, and also the locality of that service to be flexible and reactive to our needs. Once you've worked out what your need is, that all has to be put into a business case. But it's very important that that business case involves discussions with your neighbouring network trusts in our case. So we put out our service proposals to our neighbouring trusts. So we understood from them what the likely referral of stones would be from them into our new service. I've mentioned staffing, but it's really important, and a lithotripsy service, and one networked, doesn't work without admin, clerical support, nurse specialist time, and also medical support for assessing and managing and helping manage the service. Once we'd worked out what the need was, it becomes the next step is actually delivering that service. And there's various parts to delivering that service. So first of all is communicating it, what you're trying to do, and actually changing the culture with the clinical teams at various sites, and making sure they understand that acute lithotripsy is an option for those patients, whereas before it wasn't. So changing the culture from a clinical side. It's also important to make sure the operational teams at all sites are on board and understand what the implications of patients moving from one site to another may be. The referral process has to be really clear and well communicated to all centres involved. There has to be a clinical side for assessing the suitability of the referrals, and admin and clerical support to make sure films and imaging and referrals get to the right place and are treated in a promptly, timely fashion. The treatment pathway has to be understood and communicated and agreed, so the number of treatments ureteric stones may have, before they're escalated to another treatment modality. Communicating the outcomes along the treatment pathway with the base hospital and the patient, and arranging and accessing re-imaging, which may not be at the site that the lithotripsy is, but maybe at a remote unit. This generates and creates work, and your stone MDT time will increase, and nursing support and admin and clerical time will also need to increase. COVID has an effect, and as part of COVID, we understood that we needed to protect this service, and that was a real lesson for us. It's important to understand your outcomes, and we did a snapshot audit of our results, which can be seen here. But the impact on the service delivery was really fascinating, with an increase in our weekly stone MDT duration time, but a reduction in short notice outpatient appointments, a reduction in the number of people on our ureteroscopy waiting list, and a reduction in our footprint in emergency theatres for stents. So the take-home messages for me are that setting up an acute lithotripsy service and networking that across several sites has a positive impact for your stone service, and a positive impact as a new treatment option for hospitals. But communication is the key on a number of different levels, and it's a team approach to get the best outcomes. So thank you very much.
Good afternoon. My name is William Roberts from the University of Michigan. I'd like to thank Professors Turney and Renal for inviting me to participate in this session today. My objective is to speak to you about the physics of shockwave lithotripsy, specifically as it relates to coupling, energy delivery, some advanced techniques that we're working on in the lab, and a little bit on analgesia. By way of disclosures, I have relationships with Boston Scientific and Histosonics. We are all familiar with a lithotripter, an energy source that generates sound waves that are focused to a volume. The width of that energy source is known as the aperture diameter, and the distance from its surface to the focal point is the focal distance. And nowadays, we interpose a fluid cushion between the electrohydraulic lithotripsy source and the skin interface to transmit that energy, as we're no longer using water baths for the most part. Now, I want to take a moment and talk about bubbles and acoustic transmission. Air pockets and bubbles are excellent reflectors of sound waves. Their presence in the acoustic path lessens the transmission of energy, decreases the pressure at the focal volume, and results in less comminution or breakage of stone. And there are really two sites of concern: the skin coupling interface and the prefocal zone very near F2. So Jane and Pichelnikov have published on the obscuration of the aperture using traditional methods of just applying acoustic coupling gel, finding that 20 to 40% of that aperture was blocked. And when applying that technique and then targeting model stones, the crater volume, the effect of the shockwave pulse, was inversely correlated with the percentage of bubbles occluding that surface. And similarly, the pressure at the focus is decreased with presence of bubbles. And this is particularly bad after the breaking of the coupling between the cushion and the patient, and then just reestablishing that coupling. It was also learned that water-based gels that are degassed are the best coupling agents. So a couple practical aspects. First, use a water-based ultrasound gel of low viscosity. Minimize handling of that gel. Do not shake the bottle. Apply a large quantity to the center of the cushion, then expand the cushion to uniformly spread that gel from the center outwards to minimize trapping of air and air pockets. And if the coupling is broken, don't simply compress it against the patient again and resume, but repeat these steps to ensure good coupling. Now, just as air pockets at the cushion are a problem, so are persistent cavitation bubbles in the prefocal zone. This is from our lab. It's a high-speed image, video actually, of an acoustic pulse in water. And what you see are bubbles that form as the tensile component of that acoustic pulse comes through. Those bubbles then collapse, but you're left with an array of very small microbubbles that persist. And these accumulate pulse after pulse. And as the next pulse comes through and delivers a negative tensile component, all of those microbubbles suddenly expand and grow and create a shielding effect for transmission of energy to the stone. And it's been shown that this loss of tensile component to the shockwave effect results in marked decrease in effectiveness of breaking stones. So many people have shown the relationship between delivery rate for shockwave pulses and effectiveness for breakage of stone. We have shown this in the lab with our equipment as well with model stones. 120 pulses per minute requires nearly 5,000 pulses to completely comminute our stones. At slower rates, it's less. It's 60, it's 2,500, and at 30 pulses, just over 1,000. So clearly a rate dependence. And that's because of the persistence of microbubbles. That is really the problem with conventional shockwave lithotripsy these days. They persist in the acoustic path, block the transmission of energy, and result in less fragmentation of stone. So our solution as a community has been to slow the shockwave lithotripsy pulse rate to minimize this bubble shielding. And there are many papers that have studied this, including double-blind randomized controlled clinical trials, meta-analyses that have consistently shown that 60 shocks per minute yields better outcomes than 120 shocks per minute. And this trend holds. 30 is best, then 60, then 90, then 120. Higher rates are even worse. But it's very frustrating to have to deliver shockwave lithotripsy at 30 pulses per minute. Very slow, tedious. So we explored in the lab the possibility of altering that microbubble environment actively to minimize bubble shielding. So this is a device in our lab. It's a shockwave spark gap lithotripter head with an array of piezoelectric elements around it. All are focally aligned in the same focal volume. And we're able to generate a composite pulse as shown here, a typical shockwave lithotripsy tracing within a low amplitude sinusoidal pulse that follows, what we call a bubble removal sequence. You've seen the video on the top before. This is the accumulation of microbubbles with successive shockwave lithotripsy pulses. If we apply our pulse on the bottom, you see the same effect, a large bubble, and then a correct collection of microbubbles, but then they seem to coalesce together and are swept from the field. This is the result of the acoustic bubble coalescence sequence. It takes advantage of something called Bjerknes forces to cause those bubbles to come together, and they're cleared from the field. And this occurs in 5 milliseconds. It's very fast in relation to the rate of shockwave lithotripsy delivery. So it's possible to do this between every single shockwave pulse so that the next pulse coming through has a clear field and is just as effective as the first pulse. So in the lab, we demonstrated on the bench that we're able to reduce the number of shockwave lithotripsy pulses needed for complete comminution using this sequence. Nearly half the number of pulses at 120 shockwaves per minute, similarly at 60 shockwaves per minute. But at 30 shockwaves per minute, there was no difference. And this is because those residual bubbles and nuclei within the 2 seconds between shockwave pulses at that rate will dissipate and clear and not cause a problem. But if you're interested in delivering shockwave lithotripsy faster, but still effectively, acoustic bubble coalescence has potential value. And in an in vivo study in pigs, we explored the effectiveness with 1,000 pulses delivered to break down stones. And on the left is typical shockwave lithotripsy, and on the right, this composite sequence. And clearly there's better breakage on the right. And if you look at the distribution of fragment sizes, you see that it shifted greatly to the right to smaller fragments with the acoustic bubble coalescence sequence. Now, I promised I'd talk a little bit about analgesia. We know there's tissue injury during shockwave lithotripsy. There's hematuria after the treatment. And when we harvested kidneys in the lab after treatment, you can see hemorrhage arrayed out in a pattern that matches the acoustic cone of energy coming into the focus. So this occurs because bubbles that do exist a little bit outside the focus respond to the negative pressure and expand and rupture small blood vessels and injure tissue. Now, we've previously shown that we can control the focus and those effects. So these images are of what we call red blood cell phantoms. Red blood cells, when they see a significant pressure, they rupture and they lose their color. So you get a map of the pressure profile of the pulse. And on the left is a shockwave lithotripsy pulse. And this creates a zone of damage in the center where you want the highest pressures, but you see satellite lesions around it as well. But by applying pulses very similar to the acoustic bubble coalescence sequence, we can sharpen that focus and diminish this peripheral collateral bubble effect in the tissue, and very likely reduce the extent of injury from shockwave lithotripsy and likely the pain that occurs. So take home points. Firstly, bubble shielding dramatically reduces the energy transmission and the efficiency of shockwave lithotripsy. Meticulous coupling at the skin interface is very important, and better outcomes are achieved with slower pulse rates. Now, a future solution is to actively alter that microbubble environment, as we have done with acoustic bubble coalescence sequences. This will not only improve the effectiveness of each shockwave pulse, but likely allow more rapid, faster treatments that are still quite effective. Acoustic bubble coalescence also has the potential to reduce shockwave lithotripsy tissue injury. This is an area we are actively investigating currently, but this may impact analgesia as well. So at this point, I'd like to acknowledge my primary collaborator, Timothy Hall at the University of Michigan, several of our graduate students, as well as our source of funding from the National Institutes of Health, and AKSM, UMS Lithotripsy, and Richard Wolf for providing us materials and equipment to facilitate these studies. Thank you very much for your attention.
Good afternoon, my colleagues. I hope everyone is well and safe. I would like to thank BOWS committee for inviting me to be a speaker in this interesting session about lithotripsy treatment, especially at the time of COVID, and now we have the second wave, and also as a recommendation of NICE in January last year. As we know, first patient treated with lithotripsy in February 1980 in Munich, and after that in 1983, we have the first commercial machine. And on the slide, you can see different type of machine, and all these modern machines more or less have the same basics. And really what we need to talk about today, how to use the machine best to deliver good treatment with a good success rate and less complication. As we know also that more than 90% of stone on adults might be suitable for Shockwave, and this is really good news for patient, for NHS, because of cost of operation comparing with the cost of lithotripsy. We know contraindication, the common contraindication is pregnancy and bleeding, and also, of course, if we have severe skeletal malformation. Arterial aneurysm in the field of the shockwave, not only aneurysmal, also calcification of the blood vessels on the same area. If we have an obstruction distal to the stone, is of course is contraindication. So how would you really do the best clinical practice, and how would you avoid complication? We have three issues here. We have three elements. We have the patient selection, we have the machine, and we have the operator who operates the machine, if it's a urologist, radiologist, radiography, or a technician, or senior nurse. All this combination actually between the good selection of the patient, having you understanding the lithotripsy machine well, and the operator be careful, we will achieve good result, less complication. Before treating any patient with lithotripsy, please, a CT scan is essential. CT scan will use, but also more important, other the relation to the kidney to other organ. So if we see on this slide here, you can see this stone will be not suitable for shockwave because you have a lung on the way here. Again, stone like that one is the lower pole. If you do an ultrasound only, they will be reported as the stone on the lower pole of the left kidney. When here you can have the relation of the stone to the splenic flexure, Not essentially really to have a CT with contrast, except in some cases. So as I said, CT scan is essential before. Also, for example, you can see from this example, if you had only a KUB X-ray, the most obvious stone on that one is really that shadow, which in fact is in the spleen. So, and maybe the patient come on the day of the treatment, you do only an X-ray, and it can be really a disaster. So please, CT scan is essential. Review the CT scan on the day of the treatment before you start. Also, we can really provide a good one-stop SWL service. So when the patient comes to you already, sometimes there will be a gap between the CT scan and X-ray. Like, for example, if we can see this case, you have a CT scan with distal left ureteric stone, but on the day patient came for treatment, there was no obvious stone. What you do with this case, you send him home. If he's asymptomatic, you might still have the stone, but actually you can use the facility you have in your room and check. You can do fluoroscopy, you can do an ultrasound scan. And in fact, this patient, when I checked him, he had a stone still in the same position, it's been treated. So please use your ultrasound scan and use your fluoroscopy before you discharge the patient, and don't depend on the X-ray report. Only sometimes you can send patient for CT scan if you are not quite sure with the facility, but you can manage to help this patient when he comes to see you in the lithotripsy unit. Fine. So what about the machine? All the machine have this, all of them have more or less the same structure. We have three elements to the machine. We have the table and the coupling system. We have the localization and the energy delivery. And for the table, really you have to see the criteria of your table, the weight limit, how can you position the patient on the table, if the patient has to lie supine or prone, again, how the children can be treated on the table. Coming back to localization, you can have a machine with ultrasound only, you can have a machine with X-ray only, but the best really is to have the combination. The localization by X-ray and ultrasound scan. Sometimes, in fact, you need both of them in difficult cases if the stone is not very clear. So you also put the patient on the table, depending on the position of the stone. And most patients, if the therapy head is fixed, most patients will have the treatment supine, except in the mid-ureter, patient will have to lie on prone position. Okay, the second important point on localization is ultrasound scan. Ultrasound scan will give you a live image, and also you can combine ultrasound scan with Doppler technique in the same time, which you can actually have a signal here at the same time, and you can listen to this sound, which will give you the indication of a good focus, that you're hitting. Every time you hit the stone, you have a good signal. And in fact, with time, you will be able to know about stone fragmentation. And you can see the change with the frequency. You can do the same again on the VUG stone. You can use your ultrasound scan. And again, sorry for this noise, but at least you can see you can see here the ureteric jets. So it's really very good technique. By doing ultrasound scan, patient lying prone, you can see the treatment, you can see the Doppler sign that you're hitting the stone, and you also have the patient on his arm. So you can see the ureteric jet also from the other side. So using ultrasound scan for localization is actually very helpful and improve results. So we're talking about localization, X-ray and ultrasound, and if you have both of them, use them in the same time in some difficult cases, this will give you better results. So we talk about the table, we talk about localization. After that, you have your generation of the shockwave. You have to understand what type of generation. Is this electromagnetic, electrohydraulic, or piezoelectric? And also know about your machine. How big is the focus? Is only one focus or multiple focus? And again, the energy delivered at the focus area. By knowing this information, you will be able to decide how many energy level required, how many shockwave required, and also the energy level you need to reach to avoid complication. Use your machine as you use your ureteroscope and the laser. So actually use the benefit of the shockwave rate Again, as we know, the Shockwave rate for fragmentation, if you have a slower rate, is better than a higher rate. And again, number of Shockwave depend on the type of the machine. Every machine have guideline. Please follow the guideline for the machine and don't exceed the recommended number of Shockwave, because this can cause complication. Again, and give a bit of gap for the kidney vascularity to contract and restart again gradually. This will reduce the trauma and damage to the kidney. So do you really need to stent before Shockwave? WG stent doesn't really prevent obstruction of sinus tracea, does not prevent the sinus tracea. It might prevent renal colic, but is not really essential to stent before ureteric stone treatment. Might you need to stent in a very large kidney stones if it's not suitable for surgical intervention, but ureteric stone is not recommended to stent, because in fact, even you will need more Shockwave, a number of sessions if the patient has a stent for treating ureteric kidney stone. So if we don't do a good treatment, we'll have complication related to the stone fragment. So the stone fragment can be not combined, be not complete, for another stone, or we have obstruction from sinus tracea. And all this because if we do a wrong selection of our stone, but more important, if we are not careful with the treatment, and if we have like Shockwave very fast or decreased Shockwave energy, or maybe we just finished the treatment and we haven't actually achieved good fragmentation. So I suggest keep going within the limit of your machine, but don't exceed the number of the Shockwave and the energy required. So how can we reduce the incidence of renal colic, and also how can we treat sinus tracea with Shockwave? Many theory for stone fragmentation, one of important theory is the collapsing cavitation bubble. Use this theory and use this technique for improving at the end of the treatment. When you see a good fragmentation, it's better to go for low energy, high frequency. This will generate more cavitation bubble, and these actually work on the small stone, make it even smaller, and this is reduce the risk of renal colic. And it's the same technique, we use it to treat sinus tracea. And as you can see, there is 3 types of sinus tracea, which when you have a leading fragment, treat like a stone, just high energy and low frequency. But if you have many small stones like these, just actually all what you need high frequency and low energy, just like microbubble to try to make the urine escape through these ones. And if you have on the other cell diagram, just another fragment in the middle. So it's easy technique and is usually successful. We have used it for treating more than 24 sinus tracea cases with success. Do we need to give medical expulsive therapy after Shockwave? I do, and actually is increase the stone, in our view, it is expedite and increase the stone flow rate and reduce renal colic and reattendance to accident emergency. I know that there is other study might not actually agree with this, with our practice. Coming back to renal injury, please, we have to be careful. This is depending on the operator. Make sure you don't just put the patient on the table and just don't screen most of the time. As I said, be careful as he's using the ureteroscope. So again, be sure about the accuracy of targeting, because might be if you don't target and you don't check regular, and instead of hitting the stone, you will be hitting the lower pole more with high energy. So again, observation during the treatment is essential. Other factor, hypertension, might be the patient is not hypertensive, but please measure the blood pressure during the presentation, during the treatment, regular, and if you find the blood pressure is high, actually stop and give patient time to rest. Coming back to importance of lithotripsy at the time of COVID. As you can see, in June, the WHO just say, oh, this is really, the pandemic is speeding up, and now we can see we have the second wave, we have how much really many admission to the hospital and ITU. And as the usual transmission of the virus is through the airborne, but however, also some study found that it can be through urine and even blood and semen. So really the atmosphere of theater increases risk for the patient and for the staff for COVID. But if you see the difference between in urology and lithotripsy at that time, and also in the future will be, will be the new norm. As you can see, in urology, we have to have all these precautions in theater. And in theater is no way we don't have this social distance. Really, you cannot achieve that one. And also the risk is much higher for transmission of the COVID. But if you can see, the lithotripsy is already COVID secure. I am sitting here with a faraway distance for the patient. I have already the X-ray screen, and I can also achieve some distance between me and the staff nurse. Everyone has the usual mask, so it is already secure from the point of COVID. This is whether it uses infection, and this will free also theater time, free the anesthetist doctor and the ITU doctor to look after the COVID patient. So please use the lithotripsy more at that time. This will help. Thank you very much indeed, and you will be welcome any question to answer. Thank you.
Hi, I'm Stephen Gordon, consultant urologist at Epsom and St Helier Hospital and part of the South West London Acute Provider Collaborative and lead for Epsom Hospital in the South West London Urology Area Network, which was formed earlier this year. Been asked to talk about lithotripsy in the COVID era. This is where we're placed in South West London and Surrey, just within the M25. And this is the area of historically we've treated patients from with lithotripsy. The outline of lithotripsy treatment within coronavirus time is going to take into account various factors: patients and their stones, risk assessment, the equipment that we have available to us, alternatives to lithotripsy, staffing, and really the timeline of coronavirus that unfortunately we're still in. So the lithotripsy unit at Epsom and St Helier Hospital has been around for over 20 years. I worked as an SHO in the unit just at the turn of the century, and then subsequently became a consultant in 2008. And we've provided the region with lithotripsy for many years, and in particular the emergency lithotripsy service for patients suffering with renal colic. And we presented that work previously. Around the world, we've seen a decline generally with the use of lithotripsy and an increase in endoluminal endourology, ureteroscopy, and percutaneous treatments for stones. And more recently in the UK, we've had nice guidance regarding the quality standards to CT diagnosis of renal colic, but also 48-hour access to treatment, including lithotripsy and primary ureteroscopy. And getting it right first time also looked at lithotripsy, the use of stents, ureteroscopy, day case work, and readmission rates. What we don't know or didn't know and still learning is about COVID-19 and how this would affect our urology services, but in particular how we maintained our stone services. So in terms of coronavirus, we knew that lockdown was coming back in March. How did we know? Well, the shelves became empty, but they started filling them with Christmas napkins instead of toilet roll. And the Corona beer, for some reason, was the only lager available. But elective work was stopping, maybe at different rates around the country. Emergency work was clearly carrying on, but again, to different degrees. I contacted local colleagues, particularly relating to urology, but also stone services in South West London, but also contacted Darren as chairman of the section. And we decided to phone a few friends around the country. In particular, I contacted first Andy Symes. Andy used to work with us at Epsom before moving to Brighton, and he's published his work on a virtual stone clinic for patients presenting with renal colic. And I wanted to understand how he ran that, but also his lithotripsy unit. These are the areas of the country where consultants I spoke to or messaged and had some feedback. There was a lot of concern regarding staffing of lithotripsy units, at-risk staff being redeployed, cross cover potentially was maybe talked about across the region when there was more than one lithotripsy unit. And urologists were stepping up. When they weren't operating, they would say, well, maybe we should run the urology service directly ourselves. Patients had transport issues. They are actually willing to travel. It was an excuse to get out if going for medical appointments, but some of them found they couldn't even leave emergency departments, couldn't get taxis or public transport. Regional services were clearly important, and people realized, I think, the benefit of maintaining that acute lithotripsy service. And a lot of patients who had set up those primary ureteroscopy services had actually lost them due to loss of theatres and concerns regarding anaesthetics and PPE. Some urgent ureteroscopy was done in the independent sector, and even one area moved their lithotripsy unit into the independent sector to maintain that, as that was the service they could offer. It was interesting how people changed their analgesia protocols, and I think it was Oxford that had a direct access to lithotripsy from A&E. And interestingly, talking to people in the north who were saying, how bad is it really down there, Steve? How bad is coronavirus? Waiting to see what was coming as they were preparing, but not seeing the cases. And unfortunately, I think that's why we're seeing some peaks now from northern colleagues' hospitals. And sadly, I heard of a death of a patient after lithotripsy, and this really brought it home about how we were treating other conditions, not just coronavirus, but there was a fear about coronavirus, and a patient who had lithotripsy was worried about attending hospital when she developed pain and fever, attended a different hospital from where the lithotripsy was provided. COVID was ruled out as the cause of her infection, and she was placed on a medical ward, but unfortunately her septic obstructed kidney was not picked up soon enough. We even contacted colleagues in America. We had Zoom conversations with colleagues out there. Khurshid Ghani's previously come to BAS and talked about their quality improvement program to offer to measure how patients have complications maybe after surgery, the amount of admin support that is needed for that, but also the importance of giving patients good information. And Andrew Portis has previously talked about his decision-making tool regarding ureteroscopy or observation. And I wondered if we could use this as some kind of remote tracker for patients with renal colic. Also spoke to John McGrath and had a message from Simon Harrison in Getting It Right First Time. And this was some data shared from Simon's visits around the UK a few years ago. And it clearly can show the number of treatments offered when there is a fixed lithotripter are far greater than when there are mobile units. And it turns out that a lot of the mobile lithotripsy service was stopped during the main peak of coronavirus. And there are clearly some units not using lithotripsy at all. Also went to the industry, and I have a good relationship with colleagues with Storts, and Storts have a good penetration of their lithotripsy units around the UK. A lot of the fixed sites turned out to be Storts, and they also provide a mobile service. And I raised some concerns about servicing if all of these lithotripsy units were to continue. And as soon as I said that, our lithotripter went and blew up for 2 or 3 weeks. But because of those relationships we have with Storts, they were able to ask one of the mobile companies to come in so that we only had a short downtime with our lithotripsy service. Now, we got lots of mixed messages and possibly still are, and there is some regional variation.
And so hence the message remains: stay at home to protect the NHS and save lives, unless you're in the Isle of Wight. But even in the Isle of Wight, you should still stay at home to protect the NHS and save lives.
And those messages did impact patients. And this is my daughter who took the message to stay home and stay in the house a little bit too seriously. But with careful coaxing, we have been able to get our patients to come out of their homes, and certainly if they're in the pain of renal colic. And if we talk about comparing treatments, lithotripsy, ureteroscopy, these are not equal treatments to compare. We have to consider other options. Maybe in the sickest of patients, a stent and defer at the height of the pandemic is what we needed to do. But if we had lithotripsy, then maybe that's useful to use it. but not everybody has the same access or feel they have the same access to the service. And of course, coronavirus did skew our decision-making, certainly. And of course, this is what patients thought of with ureteroscopy. It's a large, sharp, pointy instrument put in somewhere where you don't really want anything to go. And this is one of our theatre staff redeployed to intensive care. So we didn't necessarily have access to the theatres. And as I say, ureteroscopy for some patients is akin to maybe sword swallowing, but in a more delicate area. In terms of decision-making for patients with true data, then the StonePass app is useful, but this is from America. Very nice app, easy to use, where patients can see numbers, but also get a visual representation of ureteroscopy and its outcomes, or choosing conservative management for renal colic. But of course, we have our own UK data from the excellent MIMIC study, and it shows really this important aspect here of upper ureteric 7mm stones really are unlikely to pass. And maybe those are the ones that we really need to focus our lithotripsy on. And as I say, locally, we know our success rates for lithotripsy in the acute patients, but there is still a problem with accessing that service. And there must be some barriers here that we need to overcome to make sure that everybody offers their patients such a service if it's available. We set up some changes to the pathway such that we wanted to reduce patients coming up to casualty too many times or to the hospital too many times. We wanted to give them information, and we set up a virtual stone clinic which ran 5 days a week, where every patient diagnosed with a kidney stone in A&E were logged in the system, and then consultant review of their case. This data is important. It's 400 cases have been discussed as part of this virtual stone clinic since coronavirus, and typically 3 to 4 patients a day. And what I'm presenting here is 100 ureteric colic patients. And I think this is the most important slide. 44 of those 100 patients had successful spontaneous passage. 36 had lithotripsy, and these are the numbers who had ureteroscopy. And clearly there were some stents put in that went on to endoscopic management. And you can see that we didn't use lithotripsy on all patients. We did certainly give conservative treatments a go, but certainly in upper ureteric stones, it makes sense to treat those patients as quickly as possible. And you can see the size of the stones that we treated conservatively and then with intervention. Some other metrics, another benefit in the coronavirus time was that we got rapid access to CT with a formal report very quickly. That may be changing again now because of problems with radiologists working different hours now. And so often we're getting that CT still within 24 hours, but not at the point of care. And often patients are coming back to the hospital. And these are some of our times to intervention. We also devised a conservative management letter and sent that to patients to explain their condition, and that helped our administrative staff and also reassured patients that their case had been reviewed by a urologist. And there were real training benefits in this time, which were listed here. And actually, we're hoping to use this and what we've learned over this time to develop a fellowship of training and also work within the urology area network to improve training. So to finish, this is being recorded in October. We don't know what's going on with the cases. Are we going to see a true wave? We're also potentially seeing more complex cases, and we've got this holding pattern of stone cases and other urology cases waiting to get into theatre. So my final slide really says that stones and colic have continued during the global pandemic. The availability of lithotripsy and models of provision around the UK are really important to look at. In all areas of urology, stone services have probably had to continue most during this time. And lithotripsy is a great tool that we've been able to use more than ever alongside ureteroscopy. Understanding the number of patients able to have lithotripsy alongside those that have to have ureteroscopy is important. The very patient-focused improvements in care that we used during COVID, such as immediate access to CT, reducing attendance and admission, remote working, improved communication with patients, and expeditious management of patients who really needed it, will hopefully continue the development of modern stone services. And as I said, it's always important to get the numbers right and understand your numbers.
300,034, 974,000 tests.
But thank you for listening.